It's really a pleasure for me to be here and to be able to talk about a topic that may not have been the first thing that came to your mind when you decided to come to an open DataFest. But in consideration of the topic and the timing of this event, I thought it was highly appropriate to quote Dr. Martin Luther King Jr. In March of 1966, he said, "Of all of the forms of inequality, injustice in healthcare is the most shocking and inhumane." Unfortunately, I'm not sure that Dr. King would be all that pleased with the current state of affairs today, which is 47 years later. And I'm going to show you some statistics that are pretty shocking and inhumane. Let's start with money, because you know what they always say, follow the money. Well, this graphic has broken down the country's wealth by race. And as you'll notice, although white Americans make up only 64% of the country's population, they lay claim to more than 88% of its wealth. If you take a look at blacks, which compose 13% of the population, they hold only 2.7% of the nation's wealth, and the 17% Latino population have only 4% of the wealth. So why does money matter when it comes to health? Well, according to a recent CNN Money article that was from December of 2013, the wealthy have more choices when it comes to doctors. This is because there are a growing number of doctors who are refusing to participate in any health plan whatsoever. Patients have to either pay up front, or some doctors are creating memberships, these packages that are also known as concierge services, where a member subscribes in order to have on-call access to their provider. And you can imagine that this is certainly something that only wealthier individuals are going to be able to take advantage of. Now, the other issue is that fewer doctors are accepting clients who are on Medicaid due to the declining reimbursement rates through that program. So for the unlucky 60+ million Americans, they are going to have longer waits to get in to see their providers, or they're going to have to travel further to find a provider who is accepting Medicaid. One's financial resources also impact the level of treatment that someone can get. So, presuming, of course, that they find that Medicaid physician. Research has shown that higher income patients get better pain management, and they suffer fewer medication errors. They also have fewer readmissions to the hospital than their lower income counterparts. And the higher income patients are likely to have a greater breadth of treatment options explained to them. Now, I don't actually think that healthcare providers are trying to treat patients unequally, but in fact, it does happen. And wealthier patients are more likely to get cutting-edge treatments. And this is either because they can pay for them out of pocket, or they have more comprehensive, better insurance plans that will cover those treatments. So as a result, wealthier Americans tend to be in better health since they have the means to buy fresh and healthy food rather than the cheaper, calorie-dense, but less healthy foods. Higher income folks are likelier to live in safer and cleaner neighborhoods and engage in physical activity. And if you like numbers, well, take a look at this. Smoking is twice as common in low income than higher income individuals. Obesity rates among lower income people is 34%, while it's 25% in the higher income group. And the percentage of people who have lost 6 or more teeth is 16% in the low income group and 5% in the higher income group. And my husband pointed out to me, since he's lost a few teeth and had a few dental implants, that as a higher income person, he's actually able to replace those teeth, potentially with better ones. But it's not all about the money. Let's look at life expectancy. As a state in California, we do pretty well. We actually rank 3rd in the US in terms of life expectancy, and we have an average lifespan of 81 years. But life expectancy is not the same for all racial and ethnic groups. In this graphic, you can see that Asian Americans are expected to live the longest in California, 86 years, and that's compared to African Americans who have the shortest lifespan of 73 years. I will just point out that is a 13-year difference, pretty amazing. And though it's not shown here, we're all well aware that there is a gender difference in lifespan. Women in California tend to live to be about 83 years old compared to men at 78 years. Then you have this oddity that I'll point out here. My pointer's not working there. Look at the Latino bar there. And you'll notice that Latinos live 3 years longer than the average Californian. And this has been called the Latino health paradox, since Latinos also have the lowest levels of educational attainment, the highest rates of poverty, or higher rates of poverty. They also experience language barriers and low rates of having health insurance. So why are they living longer? Well, we know that acculturation is also a part of the answer and part of the issues that come forward. Latinos who were foreign-born and came to the United States tend to have better health outcomes than those who were born here or have lived here for 15 or more years. But of course, there's no guarantee of better health. Even if you are Latino, it turns out that young Latino men have homicide rates that are 3 times higher than the California average. Another thing that you can't see in this chart is that life expectancy also depends on where you live. So San Francisco residents have the greatest life expectancy of the 5 most populous metropolitan areas in California. They live to be about 81 years. And the Riverside San Bernardino metropolitan area has the shortest life expectancy at 78 years. And overall, educational attainment is the most important predictor of life expectancy. Adults with a bachelor's degree are expected to live an additional full year of life longer than those who don't have a bachelor's degree, even when you adjust for the race, ethnicity, and income factors. So let's see how some of this plays out with some diseases. So we'll look at heart disease. Heart disease is the leading cause of death in California. In 2010, more than 78,000 Californians died of heart disease. And these data that I'm showing you come from the California Health Interview Survey, and they look at adults who were told by a doctor that they do have heart disease. So when we break it down, we can see that as education levels increase, the risk of heart disease falls. And there's a similar relationship that exists between income and heart disease. So when you think about it, lower education and income can impact heart disease by reducing access to health care, chronic stress from poverty, and living in environments that are not conducive to a healthy diet and physical activity. Now let me drop to the bottom of this chart and note that Native Americans and Pacific Islanders have rates of heart disease that are 2 times higher than those of other race ethnic groups. So if we look at stroke death rates in California by race ethnicity, we see that death rates from stroke are declining in almost all racial and ethnic groups, so that is a really good thing. We're very happy to see that. But the rate in African Americans is still 50% higher than that of other ethnicities. And most importantly, if you look at the gaps between the racial ethnic groups, they're not narrowing at all over time. So racial ethnic disparities in stroke death also tend to mirror the racial ethnic differences in risks for high blood pressure, for diabetes, for high cholesterol, tobacco use, and obesity. And of course, it's not just physical health where we see inequalities, but it happens in mental health as well. One major focus in mental health is depression. And major depression, as you know, is common and it is a treatable condition, but if it's left untreated, it can certainly have very serious consequences. 12% of Californians have been told that they have depression. 9% of Californians have thought about suicide, and 11% of Californians have seen a healthcare provider for an emotional or alcohol and drug-related problem within the last year. Suicide resulting from depression is a leading cause of death among young people in California. So we're starting to see where now age disparities come into play. There were 3,835 suicides in California in 2010. Suicide is the 3rd leading cause of death for 15 to 34-year-old men, and it's the 2nd leading cause of death for 20 to 24-year-old women. And then we get even more complex when we talk about the interactions, since depression is more common among people with chronic disease, and it can worsen existing chronic diseases. So for example, depression is a risk factor for the development of cardiovascular disease, but it's also a risk factor for having an adverse outcome after cardiovascular surgery. So I think that I've demonstrated to you that clear inequalities exist. And I know that I'm preaching to the crowd here, but, or to the choir. The question is, what are we going to do about it? And I wanted to mention a colleague of mine, Rishi Manchanda, who wrote this book called The Upstream Doctors. And it's actually a really good read, $1.99 on Amazon if you read that way. And I have no stake in this. But I found it actually was very interesting to read. I really liked it. But he tackles this question of what are we going to do about it? And in the introduction to his book, he recounts a story. And it's a parable. And you may have heard this before. It's sometimes attributed to Saul Alinsky, but it was adapted probably from a story by Irving Zola. And here's how it goes. There are three friends, and they're standing at a beautiful river leading to a waterfall. And suddenly, they hear a small child crying out and flailing its arms, trying to stay afloat. But the child is fast approaching the waterfall. They immediately jump in to rescue the child, but then they start to see more and more children coming down the river. And they work really hard, and they're successful in bringing most of them to safety, but not always. Soon they realize that the number of children needing to be rescued isn't going down. So they redouble their efforts. And yet the children keep coming, and the current starts to get stronger. After a while, two of the three friends start to become very fatigued. They're exhausted. And then they see their third friend. Their third friend is swimming away from them upstream. And one of the friends shouts out at this person, hey, come back, where are you going? But the swimmer doesn't turn around and just keeps swimming, tired but very determined. And then eventually that swimmer turns around and says, I know, I'm going to stop whoever or whatever keeps throwing these children in the water. And that is the upstream approach. So what does that mean, practically speaking? Well, in this infographic, which came from the city of Richmond, they attempted to define the upstream and even midstream factors that, when addressed, have the potential to positively impact the downstream health of people. So you can see that some of the issues that I've been talking about, those of class or economic inequality, as well as race, ethnicity, gender, and immigration status, are key targets for upstream interventions. And this is so important because those environmental and social factors have been determined to drive 20% of health outcomes. Now compare that to medical care, which accounts for only 10% of health outcomes. And of course, another 30% can be attributed to our genetic code, and 40% is attributable to our behaviors, our personal health behaviors. So if we want to have a significant impact on improving the health of Californians, then we should be focusing our efforts on those upstream factors. And of course, those upstream factors are also known as the social determinants of health. Now, according to the World Health Organization, the social determinants of health are the conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. And interestingly, I just learned that the social determinants of health is a new topic area for Healthy People 2020. They note that improving health requires a broad approach to promote health in all policies that will create environments where the healthy choice is the easy choice. So the Healthy People 2020 website provides this model, which is divided into 5 key topic areas: economic stability, education, social and community context, health and health care, and the neighborhood and built environment. So let's go through these a little bit, and as we do, I want you to start thinking about data and how we could use data to create and measure Healthy People 2020 goals for the social determinants of health. you're going to have an exercise tomorrow that's going to put those thoughts that you have now to very good use. So we already discussed money quite a bit, but economic stability also includes employment status for individuals or parents and housing stability, like homelessness or foreclosure. And again, as you're thinking about data and metrics for these kinds of issues, you'll soon realize that it gets pretty tough. So take the homeless as an example of a highly vulnerable population that is really deserving of additional consideration and attention. But how do you count homelessness? If you're a healthcare provider, how do you contact your homeless patient with laboratory results? Or how do you discharge your homeless patient from the hospital with the resources that they're going to need to get or stay well? How do you combat the environmental forces that are worsening their health, like extreme heat or cold, poor nutrition and poor rest, and lack of sanitary facilities? It gets extremely challenging. The topic area of education focuses on high school graduation rates and then the ability to move on to higher education, like having completed the A through G subject requirements for admission to the University of California system. It also includes school profiles, policies to support health promotion, and just having a nice, safe place where students can focus and learn. The social and community context is extremely important to health and well-being. Turns out that research has shown that positive adaptation and development in adolescence, for example, depends in part on the presence of supportive parents, caretakers, caring adults, close friends, and supportive environments. In addition, civic participation, like volunteering in an organization, voting, or other kinds of public participation, improves health and well-being. So clearly the opposite, like incarceration or institutionalization, can also impact health, but in this case, it's significantly detrimental. The key topic area of health and healthcare access is not, in this case, about what that healthcare provider can do for the patient, but it's about access to those clinical and preventive services and to community-based health promotion programs and brand new health technologies. So in this case, we're talking access. And then finally, I think there's no doubt that the neighborhood in which one lives and the overall built environment impact health in many ways. We've seen increased visits for asthma in people who have low-quality housing that may have things like mold or dust or other triggers for asthma. Other aspects of the environment may determine how safe it is to exercise outdoors or the mental stress that's associated with living in a particular place. It may determine your risk for things like hay fever or West Nile virus, and it may influence whether you get your grocery at a local farmer's market, a full-service supermarket, or a corner store that may have limited selections of fresh foods. So the Healthy People 2020 program acknowledges that the social determinants of health are closely tied to place. And you're going to hear more about that from Bill Davenhall tomorrow during one of the Ignite sessions. But I want you to start thinking about what that means in terms of data. When you look at Healthy People 2020 goals for the social determinants of health, they're a bit sparse. There's only like 4 or 5 of them. Mostly they're capturing data to measure poverty, employment, education attainment, and almost exclusively from the U.S. Census Bureau. But that's it. There's nothing else. All of these other things that I've mentioned don't yet have Healthy People 2020 goals or data sources associated with them. So there's definitely a lot of work that can and should be done. So why all the emphasis on data? Well, again, I'm sure that you're all believers in this stuff, but just to say it explicitly, we need data for the following activities: to determine where and for whom inequality exists. If the data are really going to provide helpful quality information, then they should include race, ethnicity, age, gender, and geographies at levels that are smaller than counties, because we know that the county level can mask some of those important inequalities that are going on at the smaller neighborhood level. And one example is this map that's showing particulate matter pollution at the census tract level in the Bay Area. Data is also going to be used to see what works as we evaluate our programs and interventions. And I think we need to be particularly vigilant about constantly reviewing our data sets and how we're breaking them down, what kinds of things we're including to identify data gaps that may exist. So for example, there's little data available for vulnerable populations like disabled individuals, veterans, LGBTQ populations, and the homeless. So how do we obtain and maintain those data? So let's assume that we can create these data that are disaggregated by geography and the various subgroups that I've mentioned. How will open data help? Well, I can tell you that as a researcher, about 90% of all research time is dedicated to the creation, collection, and cleaning of data. So if open data policies and platforms made quality data accessible, imagine how much faster we could progress toward health equity. So perhaps you believe, as Martin Luther King Jr. said in 1966, that health inequalities represent the most shocking and inhumane form of inequality. But if you still need convincing, there's a nice article by Woodward and Kawachi that lists the reasons why we should care. Inequalities are unfair. I think that that's pretty much indisputable. But inequalities also affect everyone, since they can have significant spillover effects, like the spread of infectious diseases and the terrible impacts of drug, alcohol, and violence on society. And I think that this is really a powerful argument. I heard a similar argument made a few years ago by Chet Hewitt, who's the president and CEO of Sierra Health Foundation. And he relayed the story of how he convinced a man who had no children of his own and no grandchildren to care about the well-being of young people. So this man said, this does not apply to me. I can't relate to it. All I want to do is retire, collect Social Security, and be left alone. So Mr. Hewitt asked him, so who's going to be paying for your Social Security? He argued that the better young people are doing, the more opportunities they're going to have for higher paying jobs, which will then allow them to pay more into the Social Security system that's going to support him in his retirement and golden years. I thought it was an excellent argument. The other thing to note is that health inequalities are avoidable, and better yet, interventions that reduce health inequality are actually cost-effective. So one example of that, you may have heard a pretty famous study that was done using Medicaid data that increased access to cervical cancer screening for women in Appalachia and was shown to be a significant cost saver. So let me circle back. At the beginning, I said that perhaps not enough has changed since Dr. King discussed inequalities in healthcare, and that perhaps he may have been disappointed. But again, his words seem apropos to me as we consider the path forward, because he said, we must accept finite disappointment, but never lose infinite hope. And I know we'll take questions at the end, but I'll give you a moment if you'd like to take my contact information, because I'd love to hear from you.
So good afternoon, everyone. I'm going to continue the discussion talking about Live Well San Diego, which is an initiative in San Diego that began in 2008, but was approved by a Board of Supervisors in 2010. And this initiative was developed with health in mind initially, but we soon realized that in order to have a community that is thriving and that is safe, you have to have components that address safety and thriving. So San Diego is a very diverse population. We have 3.2 million individuals. We are the fourth or fifth largest county in the U.S., and we have a very diverse population from the one of the largest military sites with the Navy employers. We have a large we have a large, in addition to military, a large Native American population. We actually have the largest number of farms it's thought to be in the U.S., but there are over 6,000 farms in San Diego. So we also have the largest border crossing, as well as one of the largest resettlement sites for refugees in the U.S. Over 100 languages are spoken in San Diego. So this initiative was developed to address quality, efficiency, and results. The funding that we are pouring into the care of the 3.2 million, as well as the at-risk, the high need and high-risk populations, are we seeing a return on our investment? Live Well San Diego is about delivering smarter services to everyone, and also about a better informed community that engages in positive behaviors. As I stated, the general population, that's where public health has our greatest impact, but also for the other programs within Health and Human Services Agency, child welfare services, or within the county probations, they really, or mental health services, their services affect those individuals that are at risk or those individuals that have high risk and high need. So the three components ultimately for Live Well San Diego evolved into health, safety, and thriving. And this speaks to these three components: building better health, living safely, and thriving. From the beginning, it was clear, as I stated earlier, that we needed a strategy to promote better health. However, the blueprint for Live Well San Diego, as it took shape, it evolved into this larger being, if you will. And I think many of you probably experienced that as you work on initiatives. Nothing ever ends up the way you thought it would be. So what started out actually as just an HHSA initiative or program, it really spread through robust planning and involvement of our county, other 4 county groups. And actually, for each of the 3 components, one of the groups, one or more of the groups, is the champion. So for health, it's HHSA. For safety, it's going to be the public safety group. And for thriving, it's going to be community services group and LUGE, our land use and environment group. But as this spread through the county, it also spread like wildfire through the community. And all sectors all sectors that are part of the public health system came on board and wanted to be involved in whatever way that they could. So in terms of the approval process, as I stated before, Building Better Health was adopted in July 2010. Each year we go back to our Board of Supervisors with an annual report. It took 2 years to develop Live Well, or the Building Better Health component. 2 years later, the safety component was unveiled and approved by the Board of Supervisors. And then we had our 3rd year report this last October, which included both Building Better Health and Living Safely. Now, for the public health departments that are in here, after we approved the Building Better Health component, the regions, San Diego is divided into 6 operational regions. The regions took that strategic plan back to the communities and developed community forums and leadership teams, and we actually use that movement as the nidus for our community health improvement plans for applying for public health accreditation. So Live Well San Diego has been very useful in numerous ways to the agency. As I stated before, Building Better Health started out as a much smaller focus, and it really was about changing behavior. It was the 3-4-50. Nick, as we had an all-staff meeting, asked the question, what is the one thing that you can do to change the health of the community? And I cheated a bit, so I gave him this response, 3-4-50. If we can implement this is one strategy. It's certainly more than one thing, but it's one strategy. There are 3 behaviors that contribute to 4 chronic diseases that have an impact and cause over 50% of death worldwide. And in San Diego, we measure this annually for the past 10 years. Currently, it's 56%. This actually created a competition with the Board of Supervisors because they wanted their regions to have the lowest mortality. And in particular, in East Region, the first time we did this, East Region was 62%, and Supervisor Jacob was on a mission, and she actually leads the community forums in San Diego East Region to address the needs of their community. So building better health is about breaking down barriers and creating conditions that make it easier for people to live healthy lives. And from promoting parks and libraries to creating zones for vegetable gardens to using fire stations to conduct blood pressures. We're going to be doing this in February this year on Valentine's Day. All of these activities help to transform the environment in San Diego. And what I'd like to share with you now is a video that will help bring this together for you even further.
Meet Alex. He's a 7th grader in San Diego County who lives with his mom, sister, grandfather, 1 dog, and 2 cats. One day, Alex will be an architect, marine biologist, farmer, father, mentor, obese. Like 30% of his peers, Alex is overweight. 80% of children who are overweight at this age are obese by 25. If only Alex could bike to school. If only bike paths in his neighborhood were safe and close by, Alex might get more exercise, and he might not develop diabetes. Meet Alex's mom, Bernice. Bernice works for the County of San Diego. She is single, smart, a superwoman, a volunteer, a mom, taking care of 2 young children and an aging father. She cooks what is cheap, quick, easy. If only she knew how small changes can make a big difference in her family's health. On average, Americans consume 200 to 300 more calories each day than we did 30 years ago. Nearly half of these extra calories come from sugar-sweetened drinks. If only Bernice could buy fresh fruits and vegetables at her corner store or farmer's market. Meet Alex's grandfather, Charlie. He fought 2 wars, but depression is one demon he cannot conquer, not on his own. His grandchildren bring joy and purpose, but lately he's been withdrawn, isolated, lethargic. If only Charlie did not see his depression as a character flaw. If only Charlie had a medical home where his primary care doctor and a mental health specialist coordinated his care. Alex, Bernice, Charlie, you, healthy ever after. Only if we work together will these things happen. Only if we are bold enough to change our choices, our policies, our culture within.
So that's building better health. Living safely, as I stated before, came in October of 2012. There's a video that goes with this also. You can go to our county's website and see that. If you just Google Live Well San Diego, it takes you directly to the website. There are 3 outcomes, however, expected for the living safely component. And these include residents are protected from crime and abuse, neighborhoods are safe for working, living, and playing, and communities are resilient to disasters. Now, making neighborhoods safe to live, work, and play is the nexus between health and safety. And a perfect example of this is our Safe Routes to School efforts that actually was funded through our Community Putting Prevention to Work grant. In this project, public works departments and law enforcement worked with our public health services staff and staff of schools to maintain routes to school that were safe and healthy. That speaks to a community that is protected. If we talk about being safe, an example there is businesses working together with implementing worksite policies and procedures to help increase productivity and reduce operating costs. We have initiated a worksite wellness program, again, through one of our grants, the CTG grant, Community Transformation Grant, that unfortunately, as many of you have heard, the funding is ending after this third year. But we feel that these strategies help to improve the quality of life of individuals at the workplace. And finally, the upcoming 10-year anniversary of the Cedar Fires, for those of you that live in Southern California, it is recorded as the worst fire in California's history. Well, now we're training individuals, and particularly those individuals that are hard to reach, those language communities that we typically don't think about, those threshold languages, and we've been working with them to help them create a 72-hour preparedness plan. And that's going to be very useful for other strategies that we want to implement, whether it's through objectives that we need to implement for our bioterrorism grant, or even for our community transformation grant, or other grants where we need to reach those limited English communities. So we've had great results there. Thriving is currently under development, and again, this is being championed by our community services group as well as the Luge. And we realize that not only with the thriving component, but with living better health and safety, that obviously we as in county government cannot do this alone. So we anticipate that this will be rolling out with the involvement of the community. It really came in early compared to building better health, engaging the community, asking them, what do you want to see to help improve the quality of life in your community? So we anticipate that this strategy will roll out in about 3 to 5 months later this spring. No matter which of the three components that you read about or hear about, all three of them are implemented utilizing these 4 strategies: building a better service delivery system, supporting positive choices. And the second and third one, to me, really go together, because pursuing policy and environmental change make it easy to pursue positive choices. As Esty stated earlier, it makes the healthy choice the easy choice if you have policy systems and environmental changes already in place. And as we are telling the community that you have to do X, Y, and Z, we can't forget about our employees, whether it's the county government or any other large institution. Changing the culture from within, implementing those same strategies through a worksite wellness program was very important, and we've had significant buy-in there with our Department of Human Resources. Now, as I stated before, we can't do this alone. We have begun to recognize partners that have kind of drunk the Kool-Aid, if you will, and become partners of ours with Live Well San Diego. So we now, probably in November, there were 11 Live Well San Diego partners. Today, there are just about 20 Live Well San Diego partners that are being recognized. And we are inviting the community through our website that was launched in October when we issued our third annual report. There are tips there for individuals, for families, for neighborhoods, for businesses, schools. No matter what the sector in the public health system you belong to, there are tips and tools that you can utilize to help improve the health individually, but of your neighborhood and your community. And this all speaks to the collective impact. Now, when we talk about collective impact, I just want to spend some remaining time on the evaluation component, kind of to throw back to the discussion from the panel this morning, and also tying it into Esty's presentation about social determinants of health. As you see here, this is a pyramid that we've developed so that people can, in a glance, understand, get the big picture about Live Well San Diego. We have one vision for a healthy, safe, and thriving community that is accomplished across 3 components, implemented through 4 strategies. And there are 5 areas of influence where we capture data to monitor our progress and to determine if we are successful or not. And these 5 areas of influence actually sync very well, as I saw the slide, for the 5 components of the social determinants of health. And we've identified 10 indicators. While we actually vetted all of the indicators that we developed for these 5 areas of influence, there were 24. We vetted them through our advisory groups. To the county, we convened an expert, a panel expert group of researchers to give us feedback. And then we also went to the departments in the county that had some influence on some of these indicators and helped guide us on which is the best one that we should choose as that top indicator. So I actually will have a document that I'll share with you tomorrow that you can take away with you so that you can take a look at it and see if it is of use to you, but we'll have that available for you tomorrow. I'm sorry I didn't have it here today. But I just want to go over with you the 5 areas of influence: health, knowledge, standard of living, community, and social. The health component focuses on enjoying good health and expecting to live a full life. There are 2 indicators there: life expectancy and quality of life. Knowledge is learning about or learning throughout the lifespan. It is not just, but our top indicator is graduating from high school with a high school diploma. But it also looks at adult learning, other opportunities if adults didn't finish high school, other opportunities that they take to learn and improve their knowledge. Standard of living is about having enough resources for a quality life. We looked at 2 indicators there: unemployment rates and income. Community is about living in a clean and safe neighborhood. Security is the indicator there, and security really is the number, it's defined as the number of crimes per 100,000 people, all crimes including violent and property crimes. And physical environment, we actually again vetted this with our departments, and we picked air quality, while other physical environment indicators will be measured. This will be the top indicator that we'll measure. And then the third is the built environment, and here we chose the percent of population living within a half mile of a park. The last is social. And there are 2 indicators there, one focusing on the vulnerable population, which is the percentage of population who have experienced food insecurity, and then community involvement, the percentage of population members who volunteer. So those are our top key indicators. However, nothing is static. As times in the environment changes, we may change the top indicators. So this is the tip of the iceberg, if you will. Our focus is on the collective impact, and the actions that we can take collectively as a community, we feel everyone has a role to play. So no matter what the sector, whether you're county or city government, business, schools, church, or faith-based organizations, all community-based organizations, with everyone doing what they do best, they can contribute to one or more of these areas of influence and one or more of the leading indicators. So I just want to peel back the onion a bit here and just give you an example of how this really works. The actions that we can collectively take across sectors is on the left side. The results for the sectors that I've already called out, we've identified outcomes as short-term, mid-term, and long-term. In the short term, we're looking at behavior change that is driven by policy, system, and environmental changes. And then risk factor changes in the population, whether it's getting individuals to eat more healthy, to be more physically active, and then outcome changes in the population driven by the risk behaviors. And these, in turn, have an impact on the key indicator that we've identified. Here's an example of, this may be a bit difficult with the gray shading, but it basically calls out within Health and Human Services Agency, the various other departments in the county, community-based organizations, businesses, and schools, what are some programs that are already in effect that speak to whether it's healthy eating or whether it's increasing physical activity. If all of these individuals are rowing in the same direction for these specific goals, they can impact diet and exercise, therefore having an effect on decreasing obesity, decreasing the deaths due to the 3-4-50 chronic diseases, having an impact on life expectancy. And while I did not include the slide in this presentation, there was a research at UCLA comparing the FitGram statistics from 2005 for across the state. But in San Diego from 2005 to 2010, we saw a 3.7% reduction in obesity. So we know that this collective impact can work, and what this Live Well San Diego process is doing is formalizing the process and getting everyone to row in the same direction collectively, not haphazardly. And this is another example of health utilizing stats that we have from First Five Commission. They are focusing obviously on healthcare access for children, development of screening programs, and oral health initiatives. Basically, the bottom line here is that we've looked at the annual report, and even with this information, we can see how the programs that the First Five Commission, the programs are being conducted in the community, drive the needle and help to increase access to health care, decrease prevention, and decrease, again, those 3-4-50 diseases. We also have an example of education. But what I want to, with the time that I have left, we talked about this morning about collecting data of the clients that we serve in Health and Human Services Agency. I just wanted to share with you a project that we're implementing in San Diego called the KIP project, the Knowledge Integration Project. And this is to support Live Well San Diego. This strategy was initiated and includes an electronic information exchange for our county health, social services, behavioral health, physical health, and probation data. We've been working with the Gardner group for the past probably 3 or 4 years, and in the fall, an RFP actually was issued to have someone apply and carry out the scope of work that's been defined by our staff and the Gardner group. But this is a service delivery improvement to support person-centered, strength-based, and trauma-informed practice using the integration model. And again, as I stated, this is a person-centered program working with teams, schools, nonprofits, businesses, employees, employers, hospitals, and other governmental institutions, particularly county government. And what this does, it will implement new technologies and policies to enable automatic or improved abilities to perform lookup and search if a patient comes into one department or program, and if they've been to others, we can get some information so that as patients go to the different departments in the government, they aren't being seen in silos. So there can be referrals made at the time, no matter which department or program service they solicit. Collaborative delivery, service delivery opportunities are available, notifications and alerts, and we can also take this data and look at shared analytics, some predictive analytics about what is working best, who are the greatest utilizers. So this particular program has great promise for our agency and for our county. I just wanted to show you here, KIP, actually we refer to that, could be referred to as the county's health information exchange system. It will interact with our Beacon, now referred to as San Diego Health Connect, which is the San Diego Regional Health Information System, and a community information system. So again, this will contribute, we feel, to our the concept of the affordable care community. And I think I'll end there. There has been there was discussion this morning about data collection in terms of reports. I look at data collection for the purposes of this presentation in 3 different buckets. I've talked about the data collection for the evaluation of LiveWell. Then for the clients, those are the high-risk, high-need population. Then there's population data, looking at the data that we get from OSHPD at the state and comparing those data sources with Healthy People 2020, trying to really look at the health of our community. So those are the types of sources, programs, and projects that we are trying to implement in San Diego to achieve a healthy community. So thank you.
First of all, thank you both for the talk, and Dr. Wooten, excellent job actually transforming this from healthcare to health. I noticed you talked a lot about some of the at-risk populations, those that are very needy. And if you could comment on this, we've had some discussions on the federal level about open data, on how you've been working this with the FQHCs, the VA, and the DoD, since you service a lot of those populations circulate through those 3 areas with that.
Well, for the FQHCs, okay, for the FQHCs, before January 1st this year, we had the CMS population, which is our county medical services population. We employed a contractor to manage the care of that population, but we contract with the community clinics. And we've actually developed a very robust quality improvement program whereby they are expected to achieve specific HEDIS measures in monitoring the health of that population of patients. And we will transfer that process. Now these clients, these are the LIHP clients. It started out as CMS, then CMS and mostly LIHP. Most of these are now on Medi-Cal. So we will continue that process.
Other questions?
Hi, I'm Sarah Lash with the National Quality Forum, and we are partnered with HHS at the national level to think about the use of performance measures in improving healthcare and then ultimately health outcomes. Forgive me for asking a very narrow question, but I'm very curious as to how you're planning to evaluate quality of life as an indicator.
Well, we are still exploring that. We are considering QWB. But also the debate is, do you use, there are other tools out there. The one that I kind of lean towards is QWB because it was created in San Diego by researchers there, so I'm more, have a greater affinity to that one. But there are others, and so we are exploring that with our research team on which will be the best to utilize. But I feel that somehow we have to capture quality of life, quality of well-being with our clients. That's the best way to determine whether or not we're having an impact on their care, their lives long term.
Thank you. My name is Greg Bloom. I worked at a medical clinic in DC that had a food pantry and legal services and social workers on site, and they also kept a resource directory that they were able to use to refer people to other services. DC did not really have an active information and referral system. Can you speak a little bit about the challenges and opportunities of information and referral, community resource directory data, especially in the context of open data?
Well, in San Diego, we have 211, and that is really, it started out kind of as the county working with them on selected areas, but now we are contracting with them to be that provider. So for any type of referral system, we used to have a directory in San Diego, binder directory in San Diego. We no longer have that. It's electronic, and it's on 211 San Diego's website. So that's the system that we've grown in San Diego, and it's served us very well. And they can actually collect data at any given time if there are specific questions that we want them to query, the individuals that call them. And I just had a meeting for another purpose where they were in attendance, and that idea came up. So there is a lot of opportunity that we are thinking about, apart and aside from what we're already using them for, which is for referrals. But they thread health into every call that comes into their center.
And I actually love that question. I like to think about it from two different perspectives. One is in the clinical environment that I came from, academic medical center. I really think that for the electronic medical records to be supremely useful, they should connect patients to the community resources that are available to them, particularly for problems that clinicians have a hard time spending the appropriate amount of time counseling about nutrition, obesity, diabetes. There are a lot of community resources available, and I just think that it would be so easy for a smart system like an electronic medical record to find somebody's place based on their zip code or their address, a list of vetted resources that the health system keeps handy, and then it can just be on a post-visit summary. I mean, it could take the physician no time at all. So that would be one way. But then I would also say that there's at least another way, and this was mentioned in that book that I mentioned, The Upstreamist Doctors, and they talk about essentially crowdsourcing that community information and asking people or the clinics themselves to start gathering those resources and then making them available in some sort of a machine-readable format. And a lot of people fear crowdsourced information because of the potential level of accuracy, but there are studies that show that it can be actually very good, and most people do attempt crowdsourcing with sincere intentions.
Okay. Oh, one more question. There you go.
Good afternoon. Thank you for your talks. Rand Miyashiro, San Mateo County, formerly of the CMS program, I need to add, in San Diego. But my question is, when you're looking at this data for potential inclusion in an open data like program, what are the limits in granularity? How specific do you get before you're worried that de-identified data becomes actual identified data?
I'll start. It's an easy and a hard answer. The easy part is it depends. And it depends on the data set. I mean, I think every data set has a different level of granularity that's going to be acceptable. You know, if you have a data set like birth records, I mean, you can probably get to a pretty small area and aggregate those births by things like number of prenatal visits, and it's still going to be HIPAA compliant and California Information Practices Act compliant. But for a rare disease, obviously, you're going to have to up-aggregate to county and, you know, depending on the rarity of the disease, maybe even state level or regional level. So it's easy and it's hard. It depends. And I think every single data set is going to have to be analyzed independently. And that's why I think when you consider open data portals, you need to have a data governance body that analyzes these issues specifically and studies for each data set what is the appropriate level.
Yeah, I agree with everything that Esty said. It depends upon the request and the data set that you're looking at. Comes to mind for me is PRAs. Often those requests come in looking for specific data information, but depending upon the request, and I go back to influenza, particularly during H1N1, they wanted to know what were the zip codes. So we told them no, because number one, just the zip code that you live in may have nothing at all to do with where you contracted the disease. So then that would give a false assumption to the community about where this disease was. But if you have if you have large numbers of people that are infected, where there all throughout the community, then that way you can provide, still the information would be de-identified, but you can provide zip code information. So it depends upon the prevalence of the, particularly when you're talking about disease situations, the prevalence of the disease and the volume, how many cases that have been reported to the county.